So once again, just check your audio, sir.
Can you hear me?
Yes, sir. Okay. So probably you can, yeah, closer to the system, like makes it like better. Thank you, sir.
Just wait for a couple of minutes and then start.
Sure, sir. Sure.
7 on my phone, so 7172 like that I'll start.
Sure, sure, sir. Sure.
Good evening to everyone. Primarily, this session is intended for all the youngsters in cardiology. I am probably going to take about 3 sessions. The first session will be concentrating on how to interpret pressure traces. Sorry, how to interpret pressure traces, what are the possible artifacts, how to assess the severity of gradients, how to decide on lesion severity, some physics involved in pressure traces. I'm keeping my chat box open. Since this is a session primarily meant for youngsters, you can shoot the questions then and there. I'm going to be a little bit slow. Time is not a constraint, but clarity of concepts is the main aim now. I'll start with pressure assessment. This is a right atrial pressure curve. What we see here is a tall A wave, which is going up to around 13 millimeters of mercury, followed by a deep X descent. Then there is a V wave, a Y descent, again a tall A wave. Now in terms of interpretation, A wave of around 13 millimeters of mercury, so it is elevated. Mean pressure is more than 8 millimeters of mercury, so it is elevated. If you carefully look at it, we can appreciate that there is a C notch. The pressure progressively increases on expiration and progressively falls on inspiration, which indicates a normal respiratory variation of the right atrial pressure. Now, this is a pressure wave. What is a pressure wave? It is a complex fluctuation of pressures at different moments of time. Or in other words, complex periodic fluctuation in pressure. Or in other words, complex periodic fluctuation in force per unit area. So, this is a waveform. Now, how do we assess a wave? Suppose, let us assume that I have a heart rate of about 60 and assume that each waveform will be like a simple sine wave. My heart rate is 60 per minute or 1 per second, or in other words, 1 hertz. That 1 hertz is called as the fundamental frequency. If I break it into multiple fundamental frequencies, that is called harmonics. So for a hypothetical value of a 1 Hertz sine wave, second harmonic is 2 Hertz, third harmonic is 3 Hertz, 10th harmonic is 10 Hertz. Now, if you are able to capture up to 10 Hertz, the finer high frequency deflections also can be detected. So what are the high frequency deflections? For example, in a left ventricular trace, the end diastolic flick will be a high frequency deflection. In an aortic trace, the dicrotic notch will be a high frequency deflection. In a right atrial wave, the C wave flick will be a high frequency deflection. So if I am able to capture up to around 10 harmonics, I will be able to capture even the finer high frequency deflections. Now, this is the frequency that is happening in our body. Now we are detecting it with the fluid-filled transducer. So the transducer should have an ability to respond to the oscillations that is happening in our body. So now if you see this curve, this is the frequency and this is the amplitude. Amplitude is the output to input ratio. That means if, for example, I am able to give one input frequency and I am able to get the same amount of output frequency, that means the amplitude is roughly 1. But for every transducer, there is something called as a natural frequency. The natural frequency is the frequency at which the fluid-filled transducer system will oscillate on at the maximum. So this is the natural frequency of any particular transducer. So each and every transducer will have its own natural frequency. Now why should we know about this natural frequency? At this particular natural frequency, the output will be terribly high. Like if I am able to give an input frequency exactly at that natural frequency, the output will be extremely high. And if it is extremely high, we will not be able to assess it at all. So we need to have all the frequencies to be assessed in the straight part of the curve and not on the ascending part of the curve. And we should be trying to reduce this marked increase in the amplitude during the natural frequency. So there is something called as frequency response. Frequency response is the output to input ratio for each and every frequency that is coming. I already mentioned, if suppose the heart is taken as 60 per minute, 1 per second or 1 Hertz sine wave, and we want to pick up all the high frequency deflection, we need to go up to 10th harmonic. That means 10 Hertz we should be able to pick up at a heart rate of 60. Now, if my input frequency is in this range, my output to input ratio will be optimal. So the higher the natural frequency of the system, that means the natural frequency is later and later and later, the frequency response will be longer and longer. The shaded area is the frequency response. The frequency response will be longer and longer. So a good transducer should have a high natural frequency and a lot of frequency response. Frequency response is this shaded area where the output to input ratio is optimal. So now let us see, this is the natural frequency of this particular transducer. And if I am giving an input frequency for the first some time, the initial input frequency, if it is about, let us assume, the initial 30 to 40% of the natural frequency, I will be able to get a meaningful response. After that, what happens? It starts to send an output which is very high. And this phenomenon is called as resonance. So the transducer will resonate at that frequency. So we don't want a resonance. So there is something called as damping. So we try to cut down the response. So damping is a method of cutting down the output to input ratio progressively. So as you are increasing the damping, that's called as the damping coefficient, slowly you are able to bring down the input to output ratio to almost like a flat line. And you are able to maintain it for a much longer line as a flat line. So what now? We are having a frequency response of something like around the initial 60 to 70% of my natural frequency I can utilize. Subsequently, the wave will have a lower and lower and lower output so that it will become less useful for clinical purposes. So the natural frequency of any transducer has to be about roughly 3 times the 10th harmonic of what we intend to record. So if the pulse is too fast, let us assume the heart rate is 120, the 10th harmonic is 20 Hertz. So now the damped natural frequency that is needed for us should be at least 60 Hertz. Or in other words, if I want to record a particular frequency, I need to have a transducer which is able to have a damped natural frequency of 3 times of the 10th harmonic. So now coming back, if let us assume that this natural frequency is somewhere around 60 Hertz, anything that is happening up to 20 Hertz easily I will be able to capture. So the natural frequency of most of the clinically used good transducers in the cath lab will have a pressure, an ability to assess pressures that are appropriate in the cath lab measurement purposes. Whereas when we are having a transducer in the ICU or when we are having a transducer in some other areas where the fidelity need not be very high, the natural frequency will be lower and lower and lower. So our ability will be only to pick up a very small area of frequency response. So in other words, it will not be possible for us to see a C wave, possible for us to see a dicrotic notch, possible for us to see a left ventricular end diastolic flick on an ICU transducer, but in a cath lab transducer we will be able to see, because the cath lab transducer's natural frequency will be much higher and the ICU transducers will be having a natural frequency which is much lower, and when it is much lower, the frequency response, that is the box of area where we will be able to record, will be shorter and shorter. So this is basically the principle of this curve. So again coming back, pressure wave is a complex periodic fluctuation in force per unit area. So each and every pressure is dependent on, the word pressure is dependent on a factor called area. The larger the chamber, for the same force, lower will be the pressure. Lots of clinical application for this. I'm directly going into something advanced and then I will come back to basics. 2 patients with aortic stenosis. One patient with aortic stenosis is an elderly lady of around 65 to 70 years, senile calcific aortic stenosis with a small aorta. Another person is a 30-year-old person with a bicuspid aortic valve with a dilated aorta. Both of them are having the same aortic valve area, same level of stenosis. Left ventricle is ejecting. There is a tight stenosis. So the pressure drops. The pressure drops because the potential energy is converted into kinetic energy and there is a pressure loss. So there is a high LV pressure of 170 which drops down to a much lower level at the level of tips of the valve to as low as 100 millimeters of mercury. But as the blood moves further, aorta is much smaller here. So the area here is much smaller. So the pressure again goes back higher. So the pressure recovers. The pressure recovery is due to smaller size of this aorta. Whereas in the bicuspid aortic valve, with the dilated aorta, not much of pressure recovery happens because the area is already high. So what happens? Here, the gradient, the pressure from LV from 170 came down to 100 and then recovered to 145 millimeters of mercury. Here, it dropped from 185 to 145 and just gained very minimally. So, the pressure is dependent on the area. What is the clinical significance of these two? What we are assessing is the amount of pressure drop at this particular point on the echocardiogram with our peak instantaneous Doppler. So I get a peak instantaneous Doppler measured gradient of more than 64 millimeters of mercury and more than 40 millimeters of mercury mean to qualify this lady as severe aortic stenosis. But I take up this lady for a cardiac catheterization, and when I put in the femoral artery catheter and a left ventricular catheter, my gradient is only 30 millimeters of mercury. It was much lower. Why it was low? I estimated this aortic stenosis based on the exact pressure drop that happened from the left ventricle into the tips of the aortic valve. The pressure recovery that happened resulted in a lower gradient. So this is one of the reasons why some of the patients who are taken up for an aortic valve replacement based on echocardiographic gradients in the cath lab, especially if they are senile, calcific, elderly ladies with small ascending aorta, will not have the same degree of gradients, may have 35 or may have 30 millimeters of mercury, and this phenomenon is pressure recovery. Whereas that doesn't happen often in a bicuspid aortic valve in a youngster who has got a severe gradient, and this gradient will be matched with the cath gradient that you get in the cath lab. So the phenomenon of pressure recovery, why it recovered was because this was a smaller area. Why we were discussing this? We need to understand pressure wave is a complex periodic fluctuation in force per unit area. The same corollary, you have a patient, an elderly patient who is having a restrictive left ventricle or heart failure with preserved ejection fraction. So there is a question now, where to place the aortic catheter during cath, just above the valve or where the recovery happens. You will be able to keep the catheter only in the place where complete recovery has already happened. You will not be able to take a pressure at the tip of the aortic valve. For practical purposes, what we will be getting as the gradient will be a pressure transducer in the ascending aorta and a pressure transducer in the left ventricle, and there will be already a pressure recovery. But the echocardiography does not recognize this. Echocardiography still goes by what is the pressure drop at the level of tips of the aortic valve. So aortic valve, I'll be looking at the chat box and I'll be answering those questions immediately. And so people who are not looking at the chat box, you'll be wondering why I am deviating. So please open the chat box, all of you also, so that you will know the question and immediately I am coming back. Now coming back to this trace, a patient with a heart failure with preserved ejection fraction, when he is given a fluid bolus, there is a much higher elevation of LA pressure with even a gradient between the LA pressure and the LV pressure in patients who are having a normal sized left atrium. But in a patient who is having a markedly dilated left atrium, the amount of pressure rise will be less. The same corollary in multiple areas can be given. A patient will tolerate an acute aortic regurgitation due to an infective endocarditis if the patient is already having a dilated left ventricle. But if the patient is having a small left ventricle, as in left aortic stenosis with a preserved left ventricular function, if you create a severe aortic regurgitation due to infective endocarditis or due to balloon aortic valvotomy, the amount of pressure elevation in the diastole in left ventricle or elevation of the left ventricular and diastolic pressure will be many-fold higher. So in other words, it is the area, the force per unit area. So pressure is dependent on the chamber's dimensions. Now coming back to pressure measurement. I told that a heart rate at around 60 per minute can be called as 1 Hertz, and in order to, okay. There is a question from another person, why in bicuspid aortic valve no pressure recovery? The reason is the aorta, distal aorta is dilated. When the distal aorta is dilated, basically what is the reason for pressure recovery? It is the vascular impedance. So the smaller the vessel, the higher the impedance and the pressure rises. The hugely dilated ascending aorta of a bicuspid aortic valve does not increase the pressure. So it is called as valvular arterial impedance. So arterial impedance is higher in a smaller aorta and lower in a larger aorta. So bicuspid aortic valve with the dilated aorta will have no pressure recovery, whereas a senile calcific aortic stenosis with a small aorta will have a much higher pressure recovery. Just introducing the concept. Whenever aorta is very small, pressure recovery is high, aortic stenosis by echo will be overestimated than what you see by Cath. In a dilated aorta, mostly the Cath and the echo will be matching. So coming back to this pressure measurements, first harmonic, it goes on to second, third, fourth, up to 10th harmonic. If you are able to pick up to 10th harmonic, even the smaller high frequency deflections like an end diastolic trace will be detected. So the essential physiological information is contained within the first 10 harmonics. At a pulse rate of 120, the fundamental frequency is 2 Hz. So the 10th harmonic is 20 Hz. So if we are having a flat frequency response up to 20 Hz, we will be having a perfect response. But remember, if the heart rate goes up to 180, then I need to have a much higher natural frequency. There is one more question. Whether this kind of overestimation by echo is there in PS also? Yes, it is there in PS also. However, in pulmonary stenosis, the distal pulmonary artery pressure is so low that we will not be able to appreciate this recovery. In an aorta, if from left ventricular pressure of 180, it drops to 120 at the level of tips of the aortic valve and recovers to 150, that means there is a pressure recovery of 30 millimeters of mercury in an extremely small aorta, will be able to pick it up. In severe pulmonary stenosis, distal pulmonary artery pressure is 20. So let us assume there is a post-stenotic dilatation of the main pulmonary artery. What is the recovery? 20, 15, 18, all will be more or less the same. So the quantum of gradient, if let us assume that I am having a severe pulmonary stenosis with an RV pressure of 100 and distal PA pressure of 20, I have 80 millimeters of mercury gradient. In another patient, there is no pressure recovery and it is 115, it is 85 millimeters, not much of difference because the distal pressure is so low. So the term pressure recovery does not make sense in pulmonary stenosis. It makes sense in aorta because aortic pressure is high. Another question, among echo and tract pressures, echo will have a higher value. Which of these values should be the criteria to refer to surgery? Echo is the gold standard. The referral for surgery for an adult calcific aortic stenosis is based on echocardiography only. The reason why I brought this concept is, if you are having a patient who is having more than 64 millimeters of mercury peak gradient and 40 millimeters of mercury mean gradient on echocardiography, and you take up this patient for, let us assume you are referring it for surgery. Surgeon goes and replaces the valve, nobody measures any actual hemodynamics, and so we don't know anything. But the same patient, when he goes into the for a percutaneous transcatheter aortic valve replacement, you have recorded a mean gradient of 40 millimeters and you take up into the cath lab and record the pressure. Sometimes the peak to peak gradient may be 35 millimeters of mercury, especially if the aorta is very small. Since catheterization procedures give us the opportunity to assess the hemodynamic gradients much better, our knowledge is much better when you refer for a transcatheter procedure, whereas in surgical procedure we don't know. Now the question is, Whenever a person is having 64 peak and 40 mean, instantaneously you are not going to be referring to surgery. There should be some other additional criteria. Symptomatic, asymptomatic. So by the time the person becomes symptomatic aortic stenosis, or by the time the patient gets some other comorbidities, usually clinically also, in true hemodynamics also, the gradient will increase. I just wanted to impart the concept of what is the relevance of the area for any given pressures. Now coming back to this slide, the essential physiological information is contained within the first 10 harmonics at a pulse rate of 120. So since the 10th harmonic is 20 Hertz, if you are having a flat frequency response in the first 20 Hertz, that is adequate. And so ideally the natural frequency has to be more than 3 times the highest, the 10th harmonic that we want to measure. Now I will come back to this slide a short while later. The natural frequency should be 3 times as fast as the 10th harmonic of the pressure measured. But it will keep, if the heart rate progressively keeps increasing further and further and further, it will fall into the natural frequency that we will not be able to record it accurately. So let us assume this is the natural frequency. If the heart rate is quite slow at around 60, all our frequency will be falling, even the 10th harmonic will be falling in this range. Let's talk about a heart rate of 120, it will fall here. If the heart rate is 180, it will fall here, and it will go into the area where the frequency response is poor. So that is the reason why at a higher and higher and higher heart rate, we will have poorer and poorer traces. The pressure measurements, the practical tips will be, in order to have a higher natural frequency. Okay, another question, how in cath lab we can ensure our cath trace is optimally damped by looking at the trace? Okay, we'll come back. The higher the natural frequency, if you want to have a higher natural frequency, you should have a short catheter, you should have a larger lumen, you should have a lighter fluid like saline, and you should have a non-compliant rigid catheter. So the catheter needs to be something rigid, it's not a very flexible tube, and it's a short catheter, large catheter lumen, and it's a lighter fluid. And higher damping will be induced by higher viscosity of the fluid, small catheter radius. Small catheter radius means, for example, a 20 Vigon that we have put in, and we want to have a very perfect pressure transducer, pressure recording, it will not be possible. Bubble, clot, spasm, attaching 3-way and making it perpendicular, these are all ways of increasing the damping. In a 3-way, if you make it straight, you can reduce the damping. If you make it perpendicular, you can increase the damping. Now, one small word I want to say. Here, I have put it as lighter liquid. That means less dense liquid. And here, there is a word called viscosity. The difference between density and viscosity. Density is mass per unit volume. How many molecules, the mass of the molecules per volume is density. Viscosity is not the same. Viscosity is intermolecular friction. How much of friction is there between the two molecules when they rub against each other? If I pour castor oil onto the floor, it will not go for a long distance. It will stop after a few centimeters. If I pour water on the floor, it will flow for a longer distance. So viscosity of castor oil is higher, viscosity of water is lower, so it flows. Why do we need viscosity? There should be movement of the fluid. My pressure is generated by the intracardiac chambers, and the cardiac chambers are now transmitting it through the fluid to the tip of the transducer. And so there should be an intermolecular friction should be low. So this friction is what is viscosity. So the higher the viscosity, a classical example, a contrast that is present will have a higher amount of damping. Now, how do we ensure our cath trace is optimally damped by looking at the trace? every waveform has got a characteristic shape and appearance on each and every chamber. So if it is fitting into that particular shape, that means it is optimally damped. I'll just give one example. A left ventricular trace in a fluid-filled transducer system should have an upstroke. It should reach its peak at the end of isovolumic contraction. And then it should have a rectangular plateau. And then it should fall on isovolumic relaxation. The tip of the diastole is the tip of the diastole. It should touch zero. And then it should raise, maintain a plateau in diastasis, make a small waveform in the end diastole because of the atrial flick, and then again rise up. So I should have an initial flick that is slightly taller than the plateau of the left ventricular systole, and I should have a tip of the diastole that should be at zero, and it should maintain a diastasis, a plateau. Now let us assume my left ventricular flick is 30 millimeters of mercury higher, and then it forms a plateau. And then in dip of diastole, it goes to minus 20, and then it comes back to a plateau at around 5 millimeters of mercury. It's not physiological. I cannot have a left ventricular pressure that goes 30 millimeters higher at the end of systole and then maintains a plateau. And I cannot have a left ventricular dip diastole going to sub-zero. I cannot have a pressure in a left ventricle less than atmospheric pressure. So, looking at the characteristics of the trace, we identify whether it is optimally damped or not. If suppose if it is under damped, you will feel all these flicks. Let us assume it is over damped. There are no flicks at all. As I told, the worst over damping will be like a sine wave configuration. So it will be like a sine wave. So the damping is assessed by us clinically in the cath lab by identifying the standard appearance of each and every chamber pressure trace. We will come to that by showing what is the standard pressure trace for each and every site. Pressure measurement can be assessed either by a fluid-filled catheter manometer, which is commonly being done by us, or a micromanometer, which is a catheter tip pressure transducer. Now, the classical example of a micromanometer is the FFR wire that you are using. There are catheters that are like pigtail catheters, which has got transducers at the tip, which can measure simultaneously the pressure and can inject, inject saline. So these are all primarily used for research purposes for assessing all the pressure volume loops. Now, the next question that has come up. If the heart rate suddenly changed in the cath lab from 60 to 120, given other things are constant, what change we should do in the setting if required? Actually, we will not be able to make the changes. The pressure transducers has got what is called as a natural frequency. If you are buying a good quality transducer meant for use in the catheterization laboratory, normally the frequency response are in the natural frequencies. The damped natural frequencies are in the range of 60 to 70 Hertz, and they are good enough in picking up all the hemodynamic disturbances that will happen at the 10th harmonic of a reasonable tachycardia. Let's assume a tachycardia at a rate of 120, which is having a 10th harmonic of 20 Hertz, will be easily be picked up by a transducer with a natural frequency response of around 60 comfortably. We will not be able to change the catheter, the transducer's fluid-filled transducer system's natural frequency every now and then. In case if you are not able to get a proper hemodynamic trace for a heart rate increase to 120, that means there is a deterioration of the frequency response of that particular transducer, and it is time to change the transducer. I'm just going to come to this particular point during the artifact, which is going to come in the next 2 or 3 slides. And so after that, there will be much more clarity. The question on how frequently a transducer should be changed. The transducers retain them as long as they are showing the representative pressure trace. Now, the representative pressure trace, again the question will be how you will identify what is the normal shape and pattern of each and every wave. We are going to come to it about 10 slides later. Now, the pressure transducer works on what is called as a strain gauge. What is strain gauge? Strain, the term strain means change in length. Delta L by L0 is strain. Let us assume I have a membrane of 2 centimeters. I am able to stretch it to 2.1 centimeter. Delta L is 0.1. L0 is 2. 0.1 by 2 is the strain. Strain gauge. And an equipment that makes me measure the strain is strain gauge. What does it do? My pressure gets transmitted onto this area. It hits the diaphragm. Now the diaphragm is stretched. The diaphragm moves. The amount of movement is the strain of the diaphragm. That strain I am going to gauge. I am going to measure. So how do I measure? I connect it to some resistors here. So I am going to be stretching some of the resistors and I am going to be relaxing some of the resistors. So these two resistors, G1 and G3, are going to be stretched and the other two resistors are going to be relaxed. And this is going to be what is called as a Wheatstone bridge principle. When I give a current through a circuit where there is variable resistance, if I am able to change the resistance in some path and increase the resistance in some path and reduce the resistance in some path, my output will be different. So the output will be reflecting how much is the strain gauge. The amount of movement of this diaphragm will come out as the amount of output. So this is the basic principle of Wheatstone bridge. 3 terms: balancing, calibration, zeroing. What is balancing a transducer? I told that we are giving a current here and we are changing the resistor and we are getting an output here. Now, if I get an output of 0, the pressure is 0. If I get an output of higher number, my pressure is a higher number. So what is balancing a transducer? Since I am continuously giving a current, there will be continuously a current output. I add a variable resistance till the output becomes 0. So balancing a transducer means I am giving a current, I am adjusting the resistance, and when I am adjusting the resistance, I make the output become 0. If the output becomes 0, I have balanced my transducer. So balancing a transducer means I am getting an electrical output 0 and my pressure transducer records 0. Zeroing the transducer. What is zeroing the transducer? This is 0 reference level. The balancing a transducer is output is 0, pressure is 0. Zeroing the transducer is now I am putting the transducer at a level where I feel is the middle of the cardiac chamber. Previously, it used to be at mid-chest level. That means we are putting the patient, there is a superior surface of the patient and inferior surface of the patient at the level of sternal angle of Louis, and mid part of that is taken as the mid-chest level, and your transducer 0 point has to be at the mid-chest level. But now lots of physics has come in, people have put in catheters into various parts of the heart, and since majority of the pressure assessments are primarily done for clinical purposes, either in the left ventricle or in the ascending aorta, they have identified that this so-called mid-chest level is not correct. It is 5 centimeters below the 4th intercostal space from the surface of the chest, and that should be the 0 reference level. Forget about all these things. 0 reference level is leveling to middle of the heart. If you say that it is mid-chest level, that is fine. If you say that with the recent research, since primarily we are concentrating mostly on the left ventricle and ascending aorta, it is 5 centimeters below the fourth intercostal space, that is also correct. Third, calibration. You need to connect the fluid-filled transducer to what to be the level, the transducer or the Dr. Salil Yunus, please make the questions complete. If you type it halfway, I will not be able to understand. What should be at the cardiac level, the transducer or the port be open to air? The port that we open to air. The port that we open to air should be at the 0 level. And then there is another question, at the level of tricuspid valve, is it true? Okay. The mid-chest level, when you take in the normal heart a mid-chest level, very often, that means the anterior surface to the posterior surface, very often it lies at the level of right and left atria. Since most of the hemodynamically significant measurements, see, like you are doing thousands and thousands of Cath, what is the majority of the heart problem in the world? Heart failure. Heart failure means left ventricular end diastolic pressure. Left ventricular end diastolic pressure is detected at 5 centimeters below the level of surface of the chest at fourth intercostal space. So that is the reason why the recent references are all 5 centimeters below the surface of the chest, because left ventricle is given priority. If you are a congenital heart person, centric on everything, right heart, left heart, go by 0 mid-chest level. Calibration is connecting to 100 millimeters of mercury standard pressure and making that 100 come to 100. So balancing, zeroing, calibration has 3 meanings. How to balance the transducer and how to change the resistance. Balancing a transducer is the transducer's output. If it is coming to 0 pressure, that means you have balanced the transducer. The change of the resistance is not induced by human beings. It is done by automated circuitry. What is the practical utility of balancing the transducer? If you don't balance the transducer, nothing can be measured. Balancing a transducer, zeroing the transducer and calibrating the transducers are 3 primary aspects of ascertaining the validity of a pressure transducer. So artifacts, what are the artifacts? Now comes the question that Anil was asking. Heart rate is 60, frequency of the heart rate is 1 Hertz, 10th harmonic is 10 Hertz. So if I am having a natural frequency of 30 to 40, I will be able to pick up all minor fluctuations in the pressure trace like dicrotic notch in aorta, end diastolic notch in ventricle, C notch of A waves, everything will be picked. Let us assume that the heart rate goes to 120, my natural frequency needs to be 60 to 80, and that is what the normal Cath lab transducer's natural frequency. Suddenly, if the heart rate increases to 180, the frequency of the heart rate is now 3 Hertz, 10th harmonic is 30 Hertz. The natural frequency needs to be 90 to 120, and we don't have a transducer. So automatically there is a deterioration. So the first artifact is rapid tachycardia, very common. When you put in a catheter into the left ventricle in a patient who is having an aortic stenosis and induce a ventricular tachycardia, immediately pressure transducer becomes dysfunctional and it stops recording accurate pressures. Calibration method was not completed. Calibration method is basically you need to connect the pressure transducers to your standard pressure. For a simple understanding, if you connect it to a mercury manometer and inflate it to 100 millimeters of mercury, and for that 100 millimeters of mercury, if you are able to get on the pressure transducers a 100 millimeter of mercury elevation from 0, that means you are calibrated. But this is what I am talking about is primitive method. There is an electronic circuitry method. You just press a button. it generates 100 millimeters of mercury automatically inside. In some of the machine, it will be 50 followed by 100. So what will happen? The machine will be at 0. It will go up 50. It will go up 100. So it's just pressing the button, C50, 100. Suppose if it is not there, that means there is something altered in the calibration. Again, flush all your ports and then recheck it. If it is not at all coming to that level, that means the natural frequency has deteriorated and so it cannot be used. There is many of the machines also has got a recalibration button. So it will automatically readjust itself to that 50 and 100 millimeters of mercury. Why I told you about mercury manometer is, in case if you want to check it manually yourself, then you can adopt it. Connect a 3-way, connect the mercury manometer to the side arm, keep inflating, turn the 3-way now towards the transducer and see whether you are able to get 100 millimeters of mercury. But this is not the recommended method. The recommended method is there are inbuilt mechanisms in each and every transducer. It will automatically give 50 and 100 a box the moment you put the auto calibration on. So the first artifact is tachycardia. Second artifact is underdamping. I mentioned if the peak of LV systole overshoots to 30 millimeters higher and the dip of early diastole goes down to -20, that means it is underdamping. Tall peaks and deep troughs are underdamping. This is a pulmonary artery trace which is underdamped, which is flicking high. It is going up to 45 millimeters of mercury and the lower bases are just going like spikes. This is a right atrial underdamped, too much of waveforms. Deterioration of frequency response. Deterioration of frequency response means we spoke about the natural frequency of 60 to 70 hertz. If suppose I have a small air bubble in the circuit, remember air bubble is always not in the translucent line that is outside. It can be within the catheter also. The property of a catheter is to adhere to air bubbles. I'll tell some example. You have a cup of water which you want to drink. Pour it from a bottle onto the glass. You will see the glass immediately. There will be water and on the sides there will be tiny air bubbles. And after a few seconds, these air bubbles will coalesce together and then come up to the top and then disappear. The initial few seconds, all these air bubbles will be adherent to the walls of the glasses. So this is basically a process of the dissolved air that is present within the water clinging on to the surface of the glass and then slowly forming itself into a bubble and then coming to the top. Same phenomenon will be there in catheters as well. You have a catheter that is running into the heart, we say epictate into the aorta. There will be some air bubble that will be clinging on. In fact, that is the reason why in surgery and all, they will be tapping the tubings when they measure the pressure with some metallic artery forceps in order to push out the air out. So similarly, there should be some, suppose if you are having small air bubble, it reduces the frequency response. That means if I am able to record a pressure like harmonic, 10th harmonic or 10th harmonic up to around 30 hertz before, now if there is a deterioration of the frequency response, now I will be able to record only 20 hertz, which means some of the smaller waveforms I will miss. So deterioration of frequency response is a phenomenon that can be permanent due to damage of the pressure transducer or can be temporarily induced by air or leaks in the circuit. So this is the frequency response. So the frequency response is going to be perfect in this area. This is the natural frequency. This frequency response will become shorter and shorter and shorter if there are air bubbles or leaks in the circuit. The whole frequency response will become very shorter. Another question, should balancing be done with three-way open? Balancing is different, zeroing is different. Zeroing is, you are telling that this is the level of atmospheric pressure, and from here onwards, whatever is positive is +1, +2, +3, +4 millimeters of mercury. For zeroing, you are opening the three-way to air. Balancing is different. Balancing is adjusting the electrical output of the Wheatstone bridge in order to get an output of 0, and that 0 is equal to 0 millimeters of mercury. Balancing a transducer is done electronically by the transducer, by the machine. Zeroing is done by opening the three-way manually by us. Catheter big artifact. Once again, I am telling you, there are some questions that are coming up on the Cath lab, and I am immediately answering. So for people who are not looking at the chat box, it will look like I am suddenly deviating to some other area. So keep the chat box open. The fourth artifact is catheter big artifact. Motion of the catheter within a chamber. One of the classical example is a Swan-Ganz catheter that you put it into the pulmonary artery. It keeps moving, it's whipping, and so there can be a pressure elevation and reduction to up to 30 millimeters of mercury, up to 10 millimeters of mercury. So this is called the catheter big artifact, which is with the catheter movement. End pressure artifact. Let's assume that I am going to measure the ascending aortic pressure. I have a multi-purpose catheter that is coming straight from the aorta and facing the aortic valve. I have the ejection of the left ventricle coming directly and hitting my lumen into the ascending aorta. So, if I have upstream end-hole catheter, my systolic pressure can get elevated by as high as 10 millimeters of mercury. What is downstream end pressure artifact? I have a right ventricular catheter, a multi-purpose catheter, which I take it into the pulmonary artery. The blood is moving away from my catheter in the pulmonary artery. So there is something like a suction effect. I will be recording a lower pressure in the pulmonary artery. So end pressure artifact is whether my end hole catheter is upstream or downstream. Another question, does the transducer balance automatically or should we make adjustments on the monitor? No, it is done. Each time you are switching on the transducer balancing is done and you should get 0 line. And if the 0 line is coming, that means it is the transducer is balanced itself. Is end pressure artifact, is it like a Doppler effect? Maybe we can call. There is a difference in the principle between Doppler effect and end pressure artifact. Doppler effect is, if I am making a sound, I emit a sound at a particular frequency and the sound goes forward. The sound now hits a resistance and the resistance comes towards me. Now that resistance reflects this sound. I have given a sound with a velocity, with a frequency of say 10 megahertz. I cannot create a 10 megahertz and my oral sound has to be between less than 20,000. But let us assume 10 megahertz I have given an input frequency. And if the object is coming towards me, the 10 megahertz will become 11 megahertz. If the object is going away from me, the 10 megahertz will become 9 megahertz. This frequency shift is Doppler principle. End pressure artifact is there is a pressure energy that is being recorded by the tip of the transducer. Into that, I am pushing in a kinetic energy of the blood impinging during each of the left ventricular systole into that into that end hole of the catheter. So, along with pressure energy, I am adding a kinetic energy of ejection. So, both together combined leads to an increase in the pressure of 10 millimeters of mercury. Maybe it is something similar, but two different physics principles. Should we use pigtail instead of end hole to avoid end pressure? Obviously. End pressure artifact is avoided by using pigtail catheter. But quite often, let us assume in a right coronary, in a pulmonary stenosis, you take the right ventricular pressure, you push in the catheter into the pulmonary artery, you record the pulmonary artery pressure. Pulmonary artery pressure, we are recording downstream, so you will record a much lower pressure than actually what is there in the pulmonary artery. So this is big. I'm able to take a pigtail catheter and put it into the pulmonary artery, but I am just explaining this is artifact. Catheter impact artifact. Catheter impact artifact is the pressure due to the impact on the adjacent structure. Normally, what is happening for a pressure? It is recording the pressure that is within the cavity. Let us assume that the transducer is touching the wall. So there is an additional pressure by the catheter impacting the wall. So let us assume I have a catheter that is going left ventricular catheter that I put it into the aortic pigtail is of the belly of the mitral leaflet is going to give a pressure artifact, catheter impact artifact. I'm getting a signal that my voice is poor. Is it so? If I am audible, okay. My voice, was it bad for a long period?
No. It was just wavering, sir. Like, yeah, it should be fine now, sir.
Okay, sorry. If the voice is not coming well, just immediately write. Okay, I mean that's fine. If you just mention once, that is enough. Catheter impact artifact is if it is impacting on any subject, there will be an artifactual elevation of the pressure due to the impact. So, ideally speaking, the catheter needs to be free in the cavity, which we cannot always maintain. A simple right atrial catheter, which is actually abutting the right atrial wall, is giving bizarre traces. That is because of catheter impact. More and more, catheter impact is found if the right ventricular catheter is impacting with the moderator band, right atrial catheter is impacting with the right atrial wall, left ventricular catheter is impacting with the papillary muscle, left ventricular catheter is impacting with the mitral band. So this also we need to understand. Peripheral systolic amplification is something that everybody knows so well. It is due to reflected wave. Reflected wave is a wave that comes from the peripheral parts of the arterial tree, wherever there is a branch point, as a wave that comes back towards the central aorta. It's also called as tidal wave because it is like tide of a sea or a tide of an ocean. And so it's called as reflected wave. And we all know that femoral artery systolic pressure will be much higher than the central aortic. So this is also an artifact. The more and more you go peripherally, the more and more systolic pressure will be there. Zero level error. You have set the zero level, but for some reason the patient moves up or down. The patient transiently gets into some amount of breathing difficulty that you put in 2 or 3 pillows underneath the shoulder in order to reduce the level of pulmonary venous congestion of the patient. So the patient moves, subtle movement, zero level errors. Balancing error. This is what is called zero drift. I have put my original calibration, original balancing in such a way that there is zero electrical output, and zero electrical output is equal to zero pressure. Now the zero will drift up or down over a period of time. You have to repeat the balancing and make it again come back to zero. So zero drift is a balancing error. There is another question. How to identify different types of artifact, like which trace is under damping and which one is due to impact on the chamber walls? Okay. This particular question will be understood after we describe the different pressure tracings in different chambers to know how a pressure tracing in each and every chamber should look typically. And anything that is atypical is one of these artifacts. So we will have more idea when we look at what is the normal characteristics of each and every transducer. Now we are just coming to the end of the errors. Calibration error. Calibration error, slowly the calibration can become wrong and you need to recalibrate. It is now, basically, zeroing error is something easy to do, because if there is a zero drift, if the pressure transducers are not making sense for you, you just say that, show me the zero, and the zero may be at -5 or +5. Then you know that there is a zero drift aside. Calibration is something different. Calibration, each time we will not be thinking that the calibration will be wrong. So now what is happening? Two transducers are there. Both the transducers are putting the same iota and each are recording two different levels. So now you again rebalance and recalibrate and then come back and you try to get both the transducers more or less record similar waveforms. So the calibration is, for practical purposes, easy for us to understand by looking at two transducers connect to the same chamber and record the same pressures. And you find out how much of difference is there between the two. And if the difference between the two is negligible, there is a 2 or 3 millimeters of mercury difference here. That's not physiologically significant. So forget it. So if it is okay, that means calibration can be accepted as similar. How to correct if pressure trace going below zero line despite leveling and zeroing properly? Ideally, it should not go less than zero line. There should be, if it is going consistently below zero line, that means there is some problem with some leak in your circuit. If you have used an over-compliant tubing, over-compliant catheter, you have used too much of three ways, taking the vertical, like the perpendicular part of the three-way rather than the straight part of the three-way. So you should try to find out if you are zeroing and then again and again if the leveling is going wrong, that means there is a problem. When we connect two transducers same time to same catheter in series, then one will interfere with another. It's like some averaging. Yes. So basically what we need to do is have two transducers connected with two parallel three-ways. Turn the first three-way and see the first trace, pressure trace. Then open the three-way in the other direction so that you get the second pressure trace, and both of them should be similar. There should not be a change. And this is just for showing you like they are similar. Ideally speaking, it should be connected in series and not in parallel. Correct, you are correct. Can we connect two three-ways in single catheter for comparing pressures? Can we connect two three-ways? Yes, that is what I was telling. In the same catheter tip, you connect two three-ways and connect one three-way to first transducer, one to second transducer, and find out whether they are matching. Can we measure negative pressure accurately with the same transducer? What is negative pressure? For example, negative, oh sorry boss. Okay. The pressure transducers that we are using primarily all are meant for recording what is above the atmospheric pressure. If suppose I am saying that my blood pressure is 120 by 80, that is 120 by 80 above 760 millimeters of mercury. This is the standard understanding. Now, pressure transducers are not meant for negative recordings. There is no calibration below zero for a pressure transducer. So it is tough. So your negative pressure cannot be measured, like subatmospheric pressure cannot be measured by the fluid filled transducer system that we are practically using in the catheterization laboratory. We are coming to almost end of the errors. Entrapment artifact. If a catheter tip is caught within a sac, is entrapped, So right ventricular apex, left ventricular apex, right atrial appendage, left atrial appendage, they will record higher pressure. So this is entrapment artifact. Progressive flattening or sine wave. You have a catheter, classical example is, you have put in a Vigan catheter into the femoral artery and you are continuously recording the arterial pressure. You are doing a right heart intervention and you just want only a pressure, aortic pressure. Slowly thrombus, platelet plug, everything forms on the catheter and slowly this original nice waveform flattens out. So the way of avoiding that will be frequent flushing with normal saline. Something that is physiology is also an artifact. Respiratory variation, marked respiratory variation is an artifact. A sudden awakening of the child. The child awakens and just subtly moves. You get a bizarre waveform. The child moves and then quietens out and sleeps. Fluid status. You accidentally give more fluid or less fluid. These are all physiological artifacts. Now we will enter into the pressures. We are going back again to the first curve that we saw. A wave, C, X descent, B, Y descent. A wave in right atrium and left atrium is caused by the atrial systole. Atrial systole is a brief event. Ventricular systole is a long event. Y atrial systole is a brief event. The delta P by delta T is very short. The amount of pressure elevation happens from 3 millimeters of mercury to 7 millimeters of mercury, only 4 millimeters of mercury or 5 millimeters of mercury. So the delta P by delta T is very short, so the duration is also short. In ventricle, the pressure, okay, sound is not coming. Am I audible now?
Sir, it's clear only, sir.
Okay, thank you. Okay, so delta P by delta T in the ventricle is very high. I have to go up from 0 to 120 and then come back to 0. So it's longer. Ventricular systole is longer, atrial systole is brief. So atrial wave is brief. So A wave is brief. A wave is like flick. It's like flick. V wave is a filling wave. V wave is due to continued venous filling. So it's a filling wave. So it's more like a dome. A wave is like a flick. Flick. V wave is like a dome. So A wave is due to atrial systole. Then there is a C wave that is due to closure of the tricuspid valve. It just produces a tiny flick on the descent of the A wave. It's sometimes also called as a carotid artifact because at the same time the carotid flicks due to the carotid systole. So then there is a continued X descent. So the X descent is contributed by two phenomena. One is atrial diastole, that means atria is relaxing after the systole, and there is a downward pull of the tricuspid and mitral annulus due to the ventricular systole. So primarily it is due to downward pull of the tricuspid annulus and mitral annulus. So this is actually stretching the atria out, so thereby causing the X descent. So in the normal right atria, X descent is the prominent descent. Atria, the ventricular contraction is so powerful that the AV valve annulus is pulled towards the ventricle and the atria is stretched. So the X descent is very powerful descent. Deepest descent in a right atrial pressure rise is X descent. Tallest wave in right atrial pressure is A wave. B wave is due to continued venous filling. So it is like a slow rise. There is continuous venous filling. There is another question. Please comment on optimization of filling status before Cath. Also, what is ideal to do if we measure unexpected rise of LVEDP after ASD defect? But we'll come to it. Should we give fluid challenge or should we give diuretics to see the response? We'll come to it. We'll come to it. We're just at the beginning of the right atrium. Okay. The V waves, there is a progressive venous filling. So it is a long wave. And then Y descent, suddenly when the tricuspid valve and the mitral valve open, there is a steep drop in the atrial pressure, and that is Y descent. We need to understand this very, very carefully. The V wave's height is dependent on number one, atrial compliance. Number 2, amount of the blood that is returning. This is very, very, very important, especially on the left atrium. Left atrial V wave will increase proportionate to amount of blood that is returning into the left atrium. Let's assume a patient with a ventricular septal defect or a PDA. Let's assume a patient with tetralogy with large aortopulmonary collaterals. Let us assume a patient with a heart failure with preserved ejection fraction or a systemic hypertension with elevated end diastolic pressure. You are giving an acute fluid bolus for that particular patient. There is a higher amount of blood that is returning into the left atrium, so the left atrial V waves become very tall. Second, atrial compliance. If the atria is very, very, very compliant, the V waves will be smaller. If the atria is non-compliant, V waves will be very tall. So in other words, if there is an atria which is very small and there is a sudden increase in the blood return, as what will happen in an acute fluid bolus, or a sudden disease that produces a large amount of blood to enter the left atrium with the left atrium not being dilated, as in infective endocarditis mitral regurgitation or catheter rupturing the mitral valve and causing mitral regurgitation, the V waves will be very tall. So V wave is primarily dependent on atrial compliance and the amount of blood return. I'm not telling the same thing for right atrium, because in right atrium, the amount of blood return is not directly going to impact on the V wave. It's more on the left atrium. So looking at the left atrial wave, you will find that the V wave is slightly prominent, A wave is less prominent. Now there are some more questions. What happens to the individual waveforms in JVP during mechanical ventilation? We'll come to it. We'll come into that. Most prominent wave is Y descent. No, most prominent wave on the right atrium is actually X descent. Y descent is less prominent. Y descent is less prominent. X descent is the most prominent wave. Now, in the left atrium, V wave is actually more prominent. A wave is relatively less prominent. Sometimes you will not be able to recognize it because there is also a respiratory variation. So, if you carefully look at, in general, V wave will be more prominent. Left atrium has got 3 functions. It's called as reservoir function, conduit function, and pump function. Reservoir function is whenever the mitral valve is closed. So during this time, LV systole, what is happening? Mitral valve is closed. So there is a continued venous return from the pulmonary vein into the left atrium, and the left atrial pressure keeps on increasing. And during this particular time, left atrium is actually a reservoir. It holds the blood. Then the moment the tricuspid valve or the mitral valve open, immediately the blood flows from the left atrium into the left ventricle, and at this particular time the atrium acts as a conduit. So it's a simple conduit. From the pulmonary vein, the blood runs into the left ventricle. From the superior and inferior vena cava, the blood runs into the right ventricle. So this is a conduit. And at the last part, it is a pump. So at this particular part, it acts like a pump. So this is the 3 functions of the left atrium. It acts as a reservoir at some time, as a conduit at some time, and as a pump at some time. Now, the question, what happens to the individual waveform in JVP or the left atrial pressure during mechanical ventilation? All these pressures will be same, retained. Differences will be, if you are since on a positive pressure, the entire pressure waves will be at a higher level. Depending on how much is the positive pressure, the higher and higher will be the waveforms. The pattern of A more than V in the right atrium, the pattern of V more than A in the left atrium will be retained during mechanical ventilation also, but the entire pressure now becomes positive. So we were talking about inspiratory decline and expiratory ascent. Normal all intracardiac pressures will have inspiratory decline and expiratory ascent. That will be reversed in mechanical ventilation, where there will be inspiratory ascent and expiratory decline. So the highest pressures or highest end diastolic pressures that we are normally supposed to record in end expiration in mechanical ventilation will be on end inspiration. The next question, clinical situation where the mean RA pressure are not reliable. For example, if CVP is 2 in a patient after ASD closure. Not able to understand the question. Now, we will now. Why is RA having taller A waves and why is LA having taller V waves? Venous filling in the atria during systole causes rise of the atrial pressure. Atrium acts like a reservoir. Right atrium is a larger atrium with a larger free wall and a larger atrial appendage, and so it accommodates more and more blood. So when it accommodates more and more blood, it accommodates that pressure, and so V wave does not rise. So A wave is the taller wave. Whereas in LA, the space is limited. Posteriorly is tethered by the pulmonary vein, anteriorly is tethered by the mitral valve. Not much of space for the left atrium. Backward, there is a spine, front, there is the ventricle. Not much of space for the left atrium to expand. And so, left atrial compliance is inherently low. Moreover, added to that, left atrial appendage is also small. So, the compliance is low. So, V waves are tall. So why V is more than A in left atrium? The reason is left atrium is inherently a less compliant chamber, and RA is a more compliant chamber. RA's compliance is given by the enormous free wall and the larger right atrial appendage. So now what do you see here? There is a inspiratory fall and expiratory increase. Okay, if you carefully look and ask which wave is prominent, since it is a variable inspiration and expiration, we need to carefully look at it to decide which is the taller wave, because in one particular beat we will not be able to see, because this is a dynamic phenomenon. All intracardiac pressures will reflect intrathoracic pressure. So every pressure will go down with inspiration and will raise with expiration. So intrathoracic pressure increase on expiration and reduce on expiration, and if it is lost, that is Kussmaul's name. Characteristic example is pericardial constriction. Why in pericardial constriction? You are taking a deep inspiration. So the deep inspiration is going to cause a fall in the pressure, because 2-3 things are happening. Number one, a fall in the intrathoracic pressure has resulted in fall in the intracardiac pressure also. Number two, an increase in the superior and inferior vena cava entry of blood into the right atrium has pushed into the right ventricle, and right ventricular ejection has improved. Number three, the pulmonary artery has become more compliant during the inspiration and allowed a lot of blood. All these three phenomena, that is inspiratory fall in the intrathoracic pressure reflecting on the intracardiac pressure, inspiratory increase of the right atrial inflow causing an increased right ventricular ejection, and increased right pulmonary artery compliance caused by the expansion of the chest. All these three has resulted in fall in the right atrial pressures, but in constrictive pericarditis, rigid pericarditis, the increase in the inspiratory return of superior and inferior vena cava is not transmitted to the intracardiac pressure. There is no increased right ventricular ejection. There is no increase in the right pulmonary artery improved compliance, because the blood is damming. The blood is damming before it enters the heart. So there is an inspiratory increase. It also occurs in right ventricular pathology. Why? I told there are 3 reasons. Reduction in the intrathoracic pressure will suck the blood inside. That sucked blood will be pushed a larger amount in the right ventricle, which actually increases the right ventricular ejection and right ventricular emptying. And there is an improvement in the pulmonary artery compliance. 3 reasons. right ventricular ejection to improve, there should be a good right ventricular contractility. If there is a right ventricular cardiomyopathy or a right ventricular infarction, it doesn't happen. Pulmonary artery compliance increase with inspiration will only happen if there is a pulmonary artery that is roomy and healthy. Pulmonary embolism, large clots that are sitting in the pulmonary artery, it is not roomy, it's not allowing the blood inside. So there is a tamponading effect. So in all these conditions, there will be an increase in the intrathoracic pressure. So Kussmaul sign can occur in constrictive pericarditis and also in right ventricular pathologies. How mean is calculated by these tracings? The question, how mean is calculated? Mean is electronically calculated by the machine. It averages over multiple cycles. Machines differ by beat to beat averaging, averaging over 5 to 10 beats, averaging over long pages. So some of the transducers, if you are having a mean, the mean, if suppose the blood pressure is steeply following, the mean will also fall along with the blood pressure. Some of them average it for 3 to 4 beats. So what will happen? The true aortic pressure will fall during a catastrophe, but the mean pressure will lag behind. Some of them will take one full page. Majority of the ICU transducers are like that. They will take one full page. So you will have a pressure transducer till the end, and then the next page will start. Only then the next page will average. So mean is electronically averaged from the pressures. All the area under the curve is average. That is how mean is calculated. Which catheters are ideal for measuring pressures in different chambers? Practicality dictates pigtail is the ideal catheter, but pigtail cannot be put in all the areas. So we have to use sometimes head hole catheter, sometimes side hole catheter. Right-sided A pressure compared to left-sided A pressure, which is more? In general, left atrial mean pressure is higher, right atrial mean pressure is lower. Right atrium will have taller A waves and smaller V waves. Left atrium will have smaller A waves and taller V waves. The actual pressure between right atrial A wave and left atrial A wave will be decided by the given hemodynamics of that particular patient. So if it is completely a normal patient with a normal hemodynamics, sometimes right atrial A waves can go higher than the left atrial A wave. So if there is something like a tiny PFO, there can be a flow from right atrium to left atrium also. Why tamponade does not occur in tamponade? Why Kussmaul does? We'll come to the question when we come to tamponade. We are going to come. I think we are a long way to go. Sometimes if suppose the time is going on, then we will cut it at around 9 o'clock and then we will resume it on some other day. Let's see how it goes on. Right atrium, whenever this is a right atrial pressure trace with a very tall A waves. So mean pressure is also high. So what is now seen here? The right atrial A waves are as high as 17 to 18 millimeters of mercury. Elevated right atrial A wave means there is either an inflow obstruction on the ventricle, that is tricuspid stenosis or mitral stenosis, or right ventricle is too thick, like in pulmonary stenosis or pulmonary arterial hypertension. So the three reasons are tricuspid stenosis, pulmonary stenosis, and pulmonary hypertension. Pulmonary stenosis and pulmonary hypertension due to right ventricle becoming thicker, or in other words, right ventricular compliance becoming low, and tricuspid stenosis due to true inflow obstruction. A cannon wave is a fusion of the V wave along with an A wave when there is AV asynchrony. So what are the reasons for asynchrony? When the V wave is contracting, when the A is also parallelly happening. Classical example is junctional rhythm and junctional tachycardia, where it will be regular cannon wave. It will be irregular cannon wave if it is third degree AV nodal block, ventricular tachycardia, ventricular pacing, where there is a VA dissociation. How to differentiate between giant wave versus cannon wave? Cannon wave is ventricle is contracting, so there is a closure of the tricuspid valve. So when the tricuspid valve closes, normally there is a C wave, and then the C wave should be followed by a continued descent as an X descent. Now that X descent is gone. At the same time, A is also contracting. So the C is now fusing with the A of the atria. So there is like a sudden shoot. So it's like cannon. The cannon is like huge bullet that is being shoot from the neck. So each time it goes like a bullet from the root of the neck into the JVP. So cannon waves, irregular cannon waves are seen in third-degree avinodal block VT or ventricular pacing, and like regular cannon waves are seen in junctional tachycardia. Absent A waves are seen in flutter or fibrillation. CV fusion is a characteristic feature of tricuspid regurgitation. So C wave fuses with the V wave with a prominent Y descent, and that is a feature of tricuspid regurgitation. So elevated V waves happen in tricuspid regurgitation, mitral regurgitation. Also, when there is a high venous return. The high venous return is especially applicable to left atrium because left atrial compliance is low. I told it is the amount of blood return plus the compliance of the chamber, both matters. Right atrium being always more compliant, increasing volume in the right atrium does not result in significant elevation of V waves, whereas left atrial V wave significantly elevates whenever there is a PDA, VSD, any post-tricuspid shunt, any aortopulmonary collaterals, it significantly increases. The normal right atrial pressures, the mean is up to around 5, maximum it can go up to 8 millimeters, and the maximum A waves can go up to 12 millimeters. Now, in order to understand what is 12 millimeters of mercury, what we are identifying from the neck is what is JVP in centimeters of water. So let's assume that I have about 8 millimeters of mercury. It's roughly around 11 centimeters of water. So one of the recommended method of assessment is put the patient on a 45-degree position. The middle of the right atrium will be 5 centimeters below the level of sternal angle of Louis. And so if there is more than 8 centimeters of water, the sternal angle of Louis to the tip of the clavicle will be another 3 centimeters. So I will be having a JVP elevation beyond the clavicle into the jugulo, into the sternocleidomastoid notch if my pressure is more than 8 millimeters of mercury, 8 centimeters of water. And if I have 2 to 3 millimeters more than that, that is pathological. Now there are also lots and lots of fallacies about this. People have identified on CT scans that from the sternal angle of Louis 5 centimeters down is not the middle of the right atrium, and hence varying calibrations, just like how I was telling about the mid-chest level, varying calibrations are being made. So today the currently accepted method is, if in a sitting position, if you are consistently able to demonstrate the mean JVP pressure above the level of clavicle, it is elevated. Left atrial V waves can go up to a maximum of 21 millimeters of mercury, and mean pressure can go up to a maximum of 12 millimeters of mercury. We should always know that V in left atrium is always higher. Now, how the valve abnormality will result in change in the atrial and ventricular pressure. Repeat the mechanism of cannon waves, please. Cannon wave is a phenomenon that happens when ventricle is contracting and the tricuspid valve is coming to the closed position. So this actually produces a small C artifact during the descent of the AX descent. So AX descent is atria has contracted causing the tall A wave, and X descent is happening due to atrial diastole. There is a ventricular systole which is pulling the tricuspid and mitral annulus towards the ventricular apex, which stretches the atria. So there is an X that is added to the X descent, and so the X is caused by a combination of atrial relaxation plus ventricular contraction, which is pulling the AV valve down. In a patient with cannon wave, as the ventricle is contracting, the tricuspid valve is closing, There was no preceding A wave because the atria was not contracting. But now the A wave is contracting because of the junctional rhythm. The same ventricle that has been, the same electrical impulse that excited the ventricle now also excites the atria. And so the atria is also contracting. So now the A wave is coming together with the C. So both together, the tricuspid valve closure with the powerful atrial contraction against a closed tricuspid valve results in enormous level of shooting up of the A wave. And this A wave comes in the neck as sudden flicks. I already mentioned A wave is a brief event and it is like a spike. Now that spike becomes a cannon because the atria is contracting against a closed tricuspid. Clinically, how to differentiate giant and cannon A wave? Cannon A wave can be seen in a patient where the wave is seen synchronous with the ventricular system. So it is synchronous with the carotid. Whereas the giant A wave is pre-systolic. So if you palpate parallelly the carotid and inspect the JVP, A wave is pre-systolic. Cannon wave is along with carotid. So both are simultaneous. Carotid, cannon together. Carotid, giant A wave is earlier, carotid is later. Now coming to pressure trace. Atrial pressure, mean pressure is significantly elevated. A wave, V wave. In earlier phases of mitral stenosis, A wave will become taller because A wave will try to pump and push the blood through the stenotic mitral valve and increase the A wave. So that is the reason why in a Doppler trace in early mitral stenosis you will find E, slow E descent, tall A wave. But as time passes, when the left atrial pressure increases more and more and more, the atrial systole fails to compensate for contracting and keeping the mean pressure low. So what happens? V waves become equal, V waves become taller and taller. As the V wave becomes much more taller, this is also contributed to some extent by the non-compliance of the left atrium. The basic rule of tricuspid and mitral stenosis is A wave should become tall. But in right side, always A wave will be taller. In left side, A wave will remain taller in the earliest mitral stenosis, mild mitral stenosis. The moment the mitral stenosis increases beyond a particular point, when the LA pressure shoots beyond a particular point, A wave cannot compensate further. So then the V wave increases progressively high. Then elevation of a V wave is an indicator that left atrial compliance is low. Mitral valve area is calculated in Cath lab using the Garlin formula, which shows what is the flow across the mitral valve divided by root of the mean gradient. The flow across the mitral valve happens only during diastole. So you take the stroke volume. Stroke volume is cardiac output by heart rate and divided by the diastolic filling period. That means flow in diastole through the mitral valve. And that is divided by 44.3 into constant into delta gradient. This is the mean gradient, the root of mean gradient. The constant added for mitral valve is 0.85. So this value becomes 37.7. So Garlin's formula for mitral valve is 37.7 root of transmitral gradient. There is a question. This trace can also be MS and MR. I will come to it in the next trace. The basic difference between a valve area calculation in the Cath lab versus a valve area calculation in the echo room is valve area calculation in the Cath lab uses the Garlin formula, which is flow across the valve divided by root of the gradient. Whereas in echo it is by continuity equation, which is the cross-sectional area into the VTI at the inflow is equal to the cross-sectional area into the VTI at the outflow. Basically, they are two different principles. Now, looking at the V wave, there is a question. The taller V wave can be due to mitral regurgitation also. True. V wave can be taller either due to significant mitral regurgitation or due to mitral stenosis with poor LA compliance. How do you differentiate? If it is severe mitral regurgitation, the VY descent will be steep down. If it is slowly descending, that means this is mitral stenosis. The left ventricle has taken in isovolumic relaxation period to come from 120 to 0 in a fraction of seconds. But the left atrium to decline from that peak of the V wave to the end of the Y descent, such a long time, that the end of the Y descent is actually seen in the middle of diastole. That means this VY descent is slow. That means this is mitral stenosis. So mitral stenosis, VY descent is slow and it is not mitral regurgitation. But if it is mitral regurgitation, VY descent will be steep. VY will steeply fall and the Y descent will be happening within the very, very early diastole. Mitral regurgitation, VY descent is steep. Now we have seen so far the atrial pressure. Now we are coming into the ventricular pressure. Now in ventricular pressure, this is the standard triangular trace of a right ventricle. Now to identify what is, we were talking about how to identify what is optimally damped. A right ventricle should have a pressure trace like this. It should be triangular in configuration. The dip should touch just 0 or being a fluid-filled transducer with some amount of underdamping, it can go to -1 or -2, but it should not go steep like this consistently. And it should be having strictly a triangular trace. This is the normal pressure curve of a right ventricle. Right ventricle will also have inspiratory variation. Every chamber will have inspiratory, expiratory variation. So right ventricle will also fall in inspiration, rise in expiration. Sometimes when I ask some of the youngsters, some people will tell right ventricle will increase on inspiration and left ventricle will increase on expiration. We need to remember, every intracardiac pressure will fall on inspiration and rise on expiration because they will be reflecting the intrathoracic pressure. So every pressure will lower on inspiration and increase on expiration. Similarly, right ventricular end diastolic pressure will also reduce on inspiration and increase on expiration. So again, there is a question. When will you measure left ventricular end diastolic pressure? Everybody will say correctly, end expiration. When will you measure right ventricular end diastolic pressure? Some people may tell end of inspiration. Wrong. It is also end of expiration. Every pressure since it goes down at the end of inspiration and every pressure since it goes up in the end of expiration, always the highest pressure is taken. Why it is triangular in shape? Why is right ventricular pressure trace triangular in shape? Left ventricle, it shoots to a very, very, very high pressure, and so it retains a rectangular pressure trace because the time of ascent is very high. Truly speaking, the isovolumic contraction time of the left ventricle is actually longer, and the isovolumic contraction phase of the left ventricle is actually longer compared to the IVCT and IVRT of the right ventricle. However, the ascent of the right ventricle is to a much, much, much lower pressure. It goes up only to 20 to 25 millimeters. Whereas left ventricle goes to a much higher pressure and it needs to be sustained till the end of systole. So left ventricular pressure trace is a rectangular trace and right ventricle is a triangular trace. Is the diastolic pressure which are discordant with respiration. No, diastolic pressure, everything will be concordant with respiration. Every pressure has to reduce in inspiration and increase on expiration. Standard rule, intrathoracic structures uniformly will have reduction in inspiration and increase in expiration. So end expiratory pressure in right ventricle will be the largest. Now, this is a pulmonary artery pressure trace that we are pulling back into the right ventricle. I am coming to pathology of the right ventricle. Right ventricular pressure is very high here, 80 millimeters of mercury. Pulmonary artery pressure is very low here, 9 millimeters of mercury systolic. So pulmonary stenosis. We will now go into what is the severity of pulmonary stenosis. And before that, let us observe this pressure trace. This pressure is very low. It's 9 by 4 millimeters of mercury. Why is it so low? End pressure artifact. The catheter, multipurpose catheter, was facing away from the pulmonary valve towards the low pressure main pulmonary artery, and so it is end pressure artifact, so it is very low. As I am pulling out, it is becoming even more lower. Here it is at least 9 millimeters of mercury. Here it is becoming 5 millimeters of mercury. This is due to what is called Venturi effect. What is Venturi effect? Whenever blood flows from one chamber to another narrowed chamber, and during that flow through the narrowed chamber, it accelerates, there is a further fall in the pressure. This further additional fall in the pressure is called Venturi effect, and this is assessed by what is called Venturi meter. So this is a glass tube with water. You are pushing air, there is a narrowing here, and because of this narrowing, there is a higher velocity of the airflow. This produces a lower pressure here. So the water gets sucked in here because there is a lower pressure. The pressure is higher here, so the pressure is low here. So this Venturi meter actually shows what is Venturi effect. So the pressure is actually low here. Venturi effect actually explains many things. The reason why vegetations get deposited on the right ventricular side of a ventricular septal defect. Why the aortic valve leaflet prolapses progressively in a perimembranous VSD. Venturi effect explains many things. And this is also Venturi effect. Venturi is the reverse of pressure recovery phenomenon. No, Venturi is actually the fall in the pressure at the site of narrowing. Pressure recovery is due to vascular impedance distal if the vessel is smaller. If the distal vessel is smaller and the impedance is very high, it's regaining the pressure. It's increasing the pressure again. Right ventricular pressure in a pulmonary stenosis is classified as a gradient of up to 30 millimeters of mercury is mild, 30 to 50 is moderate, more than 50 is severe. And if you are going by right ventricular systolic pressures, up to 30 is normal, 30 to 50 is mild PS, 50 to 75 is moderate PS, and more than 75 is severe PS. Right ventricular end diastolic pressure of up to 8 millimeters of mercury is normal. And if it is elevated more than 8 millimeters of mercury, then it is elevated right ventricular end diastolic pressure. How to know the level of obstruction? You pull back from the main pulmonary artery into the, we will complete the pulmonary artery and then come to this question. That is something simple, not very, very difficult. If you are able to demonstrate with an end hole catheter, when you are seeing the pulmonary artery, you are having a pulmonary artery systole and diastole. That means the diastole is actually not touching zero. And then you come to the right ventricular outflow tract. In the case of infundibular stenosis, the right ventricle will touch zero. So you have started having ventricular trace, and that means it is subinfundibular, infundibular pulmonary stenosis. RVSP and echo RVSP are the same. Echo RVSP uses the principle of tricuspid regurgitation. It assumes an empiric right atrial pressure based on your gut feeling about what is the right atrial pressure. The gut feeling is decided by clinical examination of the jugular venous pulsation or echocardiographic assessment of the inferior vena cava. And based on this, you arrive at the RV systolic pressure. RV systolic pressure of echocardiogram and RV systolic pressure of cardiac catheterization will match if the echocardiographic pressure signals are appropriate and adequate. There are lots of fallacies about adequacy of the right ventricular systolic pressure assessment on tricuspid regurgitation, because tricuspid regurgitation jet may be inadequate, tricuspid regurgitation may be eccentric, tricuspid regurgitation jet may not be in alignment with your echo angle of insonation. So considering all these possibilities, RV systolic pressure echo versus RV systolic pressure cath may vary or may be concordant. Where to keep the catheter for measuring the right ventricular systolic pressure? Right ventricular systolic pressure is measured at multiple levels. Right ventricular inflow, right ventricular body, right ventricular outflow. So right ventricle is measured at varying levels to identify infundibular PS, double chambered right ventricle. So depending on the position of the catheter, you will get different pathologies. Why do we generally grade PS by peak pressure, but AS by mean pressure? AS also is recorded by peak pressure. AS more than 64 peak pressure and 40 mean pressure is considered severe. Pulmonary stenosis, since it is a lower pressured pulmonary artery chamber, often the clinical significance is given only for peak pressures. It's basically a lower numbers. Yeah, left ventricular severe aortic stenosis with left ventricular pressure is going to be touching 200, whereas a severe pulmonary stenosis, right ventricular pressure will be touching 70. So peak pressures are given more significance. Mean pressures are not very often considered at all. Is Carabello sign seen in aortic stenosis? Yes. We will come to Carabello sign when we come to aortic stenosis. Just wait for a few short. So right ventricular pressure, this is the severity of the right ventricular outflow tract obstruction. Coming to left ventricular end-diastolic pressure is measured at the R wave, or the place where the isovolumic contraction starts. So at the level of R wave, or where the isovolumic contraction starts. Left ventricular end-diastolic pressure should be measured at the end of expiration, which means in a pressure transducer, whichever is the highest point will be the correct left ventricular end-diastolic pressure. Always measure in end of expiration. So keep on identifying the points and whichever is the highest is measured. Why peak gradient is taken for evaluating intervention in PS, while in other valves, this is the mean gradient. The right ventricular pathologies are not in general assessed by simultaneous pressure transducers at all. In left side, it is customary always to put in two catheters, left atrium and left ventricle and aorta. In right atrial pressure trace, right atrial hemodynamics, all the interventions are based on how much elevated is the proximal pressure. It's not customary to have simultaneous pressure transducers, one in the right ventricle and one in the pulmonary artery, and make the area under the curve between the right ventricle systole and PS systole, find out what is the mean transpulmonary gradient, and then apply the Gorlin formula. The very basic reason is you are using a single transducer in a simple disease and trying to analyze the whole pathology. Since these pressures are operating at a much lower level, very often less importance is given for all the right-sided hemodynamic events compared to the left-sided hemodynamic events. Left-sided hemodynamic events, the adverse effects are significant pulmonary venous hypertension, whereas right-sided events, the adverse effect is systemic venous hypertension. Compared to systemic venous hypertension and pulmonary venous hypertension, the former is very, very, very benign, and hence not too much of stress is given on the hemodynamics of simultaneous RV and PA trace, simultaneous RA and RV trace. Now coming to left ventricular end-diastolic pressure in a patient. This is a patient who is having an ASD device closure, whose left ventricular end-diastolic pressure is around 12 millimeters of mercury pre, shoots up to 24 millimeters of mercury post. So this results in significant elevation of the left ventricular end diastolic pressure off. And so what we are now looking at is restrictive left ventricular physiology. This is very easily understood. Now let us go back to the basics of this. Fortunately, in left ventricular end diastolic pressure, whenever it is high, immediately it reflects on the left atrial pressure. And since there is a large ASD, it reflects on the right atrial pressure. So every patient who is having an elevated left ventricular end diastolic pressure will transmit the pressure to left atrium and transmit the pressure to right atrium. That when you are putting in the catheter into the right atrium in a patient with atrial septal defect, and if you are getting a mean pressure of more than 8 millimeters of mercury, indirect evidence of restrictive LV physiology, indirect evidence of elevated LV end diastolic pressure. Already you have diagnosed. Already you have diagnosed that this is a patient who is going to develop a restrictive LV physiology. Let us assume a patient is having a left ventricular end diastolic pressure of 6 millimeters of mercury. Left atrial pressure will be 4 to 6 millimeters of mercury. Same is transmitted to the right side. Right atrial pressure is 4 to 6 millimeters of mercury. Very less likely that left ventricular end diastolic pressure will shoot up from 6 millimeters of mercury to pathological levels. So a baseline elevation of the left ventricular end diastolic pressure to 12 millimeters of mercury, which is actually due to a combination of two factors. Number one, left ventricle is having a coexistent pathology like a coronary artery disease or a hypertensive heart disease or a diabetic heart disease or an elderly due to left ventricular compliance abnormality. And on the top of it, left ventricle is volume deprived over a long period of time, creating more and more of left traction and making more and more of RB volume overload. This left ventricle will automatically start showing an end diastolic pressure elevation to 10 to 12 millimeters of mercury, which is high normal left ventricle end diastolic pressures. Immediately it reflects onto LA pressure, reflects onto RA pressure. So RA pressure is going to show definitely a pressure of more than 8 millimeters of mercury. If you have an RA pressure of 2 or 3 millimeters of mercury to start off, that patient is never going to get a restrictive left ventricular end diastolic, restrictive LV physiology, because he cannot raise the left ventricular end diastolic pressure to 24, 25 millimeters. So this is what is identified by this curve. Sometimes in some patients, you will find it, the patient may have a little bit of tachycardia. You will not be able to get a proper nice left ventricular end diastolic pressure curve in a patient with atrial septal defect. And you will be wondering, is the left ventricular EDP very high, whether the patient is going to tolerate an ASD device closure or not? In such a patient, if the RA pressure is 2 or 3 or 4, straight away it excludes a restrictive LV. Restrictive LV. It will be a tolerant LV. So if there is a restrictive LV, it will shoot up like this. Could raised LV EDP be partially due to reverse Bernheim effect? Yes, possible. But it is that's what I was telling. Left ventricular end diastolic pressure elevation is due to a combination of left ventricular smallness of the left ventricle is due to a combination of inherent LV physiology as well as underfilling of the left ventricle. So the pathology will reflect fortunately in an ASD onto the LA and onto the RA very easily, and so always you will be able to identify a restrictive LV physiology right at your beginning of the Cath when you assess the RA pressure. Now we have completed the ventricular and diastolic pressure. We are going into pulmonary artery pressures. Pulmonary artery systolic pressure on an average is between 15 to 30 and diastolic is between 4 to 12. So this is a pressure trace of a pulmonary artery which is showing systolic pressure of 65 to 70 millimeters of mercury, diastolic pressure of around 20 millimeters with a mean of 45. So there is moderate pulmonary artery hypertension. So to classify what is mild, moderate and severe pulmonary artery hypertension, if the mean pressure is 20 to 35, 35 to 50 and more than 50, some textbooks use 35 to 45, but whichever it is, you just need to understand the principles. Either it is 35 to 45 or 35 to 50, and it is more than 45 or more than 50. That is mild, moderate, and severe pulmonary arterial hypertension. Another type of pulmonary artery pressure wave abnormality, how the A and B wave morphology changes in the presence of a large AST. We will start with a normal person. Normal person, right atrial A wave is taller, V wave is smaller. V wave is smaller because RA is more compliant. Left atrium, V wave is taller because atrium is less compliant. So V tall in LA, A tall in RA. There is a large AST. Equalization. So A becomes equal, V becomes equal. So A is equal to V. The tall V of the LA now comes on to RA. The tall RA of the RA goes on to LA. So A and V becomes equal. So in a patient with ASD, A and V will be equal. This patient is now in the younger age group. As this patient gets more and more advanced age, right ventricular hypertrophy happens due to pulmonary arterial hypertension. This right ventricular hypertrophy elevates the right atrial A wave. When the right atrial A wave becomes taller, it reflects onto the left atrium also. So right atrial and left atrial A wave becomes taller. So A is equal to V as long as the heart is compensated. A becomes taller than V whenever the heart decompensates. Decompensation is due to right ventricular compliance being lost due to pulmonary arterial hypertension. If this particular patient is having a secondary pathology of the AV valves, either in the form of tricuspid regurgitation due to progressive RV dilatation or mitral regurgitation due to mitral valve prolapse, both will lead to elevation of V wave. Otherwise, A is equal to V in the compensated state, A more than V whenever there is pulmonary hypertension. So this is the standard pressure trace of an AST. Coming back to this particular pressure trace, there is a taller PA systolic going up to 50 to 55, but the diastolic is very low, 5 millimeters of mercury. So what does this mean? So this is pulmonary regurgitation. So why in pulmonary regurgitation, PA systolic becomes higher? In any regurgitation, pulmonary regurgitation or aortic regurgitation, right ventricular and left ventricular stroke volume increases. Whenever the stroke volume increases, the stroke volume leads to the percussion wave in the pressure trace. So the systolic pressure goes up. You have aortic regurgitation, LV systolic pressure will go up, aortic systolic pressure will go up. You have pulmonary regurgitation, RV systolic pressure will go up, pulmonary artery systolic pressure will go up. So systolic pressure elevation is the rule of aortic and pulmonary regurgitation, and low diastolic pressure touching 0 to 5 is the rule in pulmonary regurgitation severe. So in other words, this is ventricularization of the pulmonary artery pressure. As the patient advances with ventricular dysfunction, the pulmonary artery trace will almost match the ventricular trace by even showing end diastolic elevation. So the pulmonary artery pressure trace will start exactly reflecting the ventricle in severe and severe pulmonary regurgitation. So this is an example of a pulmonary artery pressure and a right ventricular pressure in a patient with very severe pulmonary regurgitation. So there is a simultaneous pressure trace. I mentioned a short while before. Normally we don't take a simultaneous pressure trace in any right-sided chamber because many of the interventions do not warrant such a intensive simultaneous measurement of right ventricle and pulmonary artery. But pulmonary regurgitation interventions, that means percutaneous pulmonary valve implantation, can only be assessed in its efficacy by understanding how much of ventricularization is there at the beginning. So the pulmonary artery pressure curve, which is orange, is exactly matching the yellow right ventricle, and so the pulmonary artery is completely ventricularized. So what should happen when you put in a percutaneous pulmonary valve? The pulmonary artery diastole should go up, creating a diastolic gradient. So this is a diastolic gradient. So the rule of aortic valve replacement and pulmonary valve replacement should be a good diastolic gradient should come. In other words, the pulmonary artery diastole should go up enormously higher than the right ventricular diastolic curve. So this diastolic gradient is extremely crucial. And why we are resorting to this double catheter? It's an advanced intervention. Unlike the previous simple interventions like ballooning, this is an advanced intervention where every hemodynamics count. So you take simultaneous pulmonary artery and aorta and document that there is a clear-cut diastolic gradient. That means a leak is arrested. Now, pulmonary regurgitation is common in post-tetralogy situation that I am going to show some example. This is a post-tetralogy pulmonary regurgitation. Our PA systolic pressure is 55 with PA diastolic pressure is almost 6 to 7. So it's almost getting ventricularized. PA systolic, why it went up already I mentioned, RV stroke volume is higher. So now you take the RV's pressure is also high. It's almost around 65 millimeters of mercury. There is a mild gradient of 10 millimeters across this post-tetralogy, and end diastolic pressure is significantly high. You can see that the end diastolic pressure is 20 millimeters of mercury here. So what is the pathology? The right ventricular dysfunction has started because of the pulmonary regurgitation. In early phases, there will be increasing pulmonary regurgitation, will have only mild increase of the pulmonary artery systolic pressure and mild increase of the RV systolic pressure. But as the RV dysfunction sets in, end diastolic pressure will start going up. So the end diastolic pressure elevation is leading to RV EDP going to 20 millimeters of mercury. And once this goes to 20 millimeters of mercury, you can appreciate in this pressure trace, almost it is touching 16 millimeters of mercury here. So it is significantly getting elevated. And this is reflected onto the right atrium. So right atrium now becomes mean pressure goes up with tall A waves. So this is progressive back pressure from the pulmonary artery down into the ventricle and atria. Could you explain why systolic pressure increases in ventricularization? Whenever there is aortic regurgitation or pulmonary regurgitation, the regurgitant volume comes back into the left ventricle or right ventricle. It gets added to the next cycle's stroke volume. So now the cumulative stroke volume is what normally the left ventricle should eject plus the regurgitant volume. So a high stroke volume. High stroke volume means high left ventricular systolic pressure and high aortic pressure. Same way, high RV systolic pressure and high PA systolic pressure. Every patient with AV valve regurgitation will have elevation of systolic pressure as long as the ventricle is compensating. When the ventricle decompensates, there will be decapitation. So then the pressures will fall. So if you are having a patient who is having an aortic regurgitation, the original pressure was 120 by 80, he gets a severe aortic regurgitation, his pressure will go to 170 by 40. So there is an elevation of the aortic systolic pressure, corresponding elevation of the LV systolic pressure. If that left ventricle goes on to left ventricular dysfunction, there will be decapitation of the LV systolic pressure. Again, the LV pressure will come down to 120 to 130. Left ventricle has started to fail. So that is the explanation. Explain the correlation between LVEDP with the R wave. Exactly. Actually, it has to be taken on the R wave. Books sometimes will say 0.004 seconds after the R wave, but human eyes cannot differentiate those numbers. It is R wave. So this is a post-tetralogy with RA pressure also gets elevated. So as progressively the pathology worsens in a pulmonary regurgitation, it gets reflected proximally in RA and RB. Now, this is another PA trace. I told the normal PA systolic trace is 15 to 30 millimeters of mercury systolic, but here the systolic pressure is only 10 to 11 millimeters of mercury. Mean pressure is only 9 millimeters of mercury. So it's a low PA trace. So this is the characteristic pressure trace of any pulmonary stenosis, as in tetralogy of Fallot, valvar pulmonary stenosis. It becomes very low with low pulse pressure. In aorta, you get anacrotic notch with a slow rising pulse with a low pulse pressure. Similarly, in pulmonary artery also, you get a low pulse pressure with a small pulse volume. So this is a sign of severe pulmonary stenosis. Sometimes in pulmonary atresia, how do you measure the pulmonary artery pressure? You may have to go into the pulmonary vein wedge to record the vein wedge traces. There is a question, when there is increased respiratory variation like in Down syndrome with upper airway abnormality, won't taking the end diastolic pressure in expiration alone cause an abnormally high pressure, and will it reflect the true end diastolic pressure? All the end diastolic pressures are taken to prognosticate that particular patient. So the highest pressure is taken in order to assess the worst case situation. The assumptions of all the end diastolic pressure assessment is in a steady state respiration wherein the person is having a normal inspiration and normal expiration, and the normal inspiratory and expiratory variation is within the acceptable limits of 0 to 6 centimeters of water. But if you are having a significant obstructed airways, which is causing a profound inspiratory fall and a marked expiratory rise, because expiratory pressures, end expiratory pressures in the chest will increase enormously with airway obstruction, and the inspiratory pressures will go very negative with inspiratory stridor. In such patients, if the values go extremely erroneous, then you need to put in airways. And if airway alone is not getting settled, you may have to even intubate the patient and ventilate the patient. Now, during intubation and ventilation, you may have to use end inspiratory pressures because that is the highest pressure. The moment you go into those levels, obviously you are actually going out of true physiology. Ideal hemodynamics are recorded on reasonable conscious sedation and in awake state rather than into this unphysiological environments. There are, okay, in between some more questions ran away. Kindly explain the hemodynamics of PSP, RPH in post-tetralogy hypertensive. Okay, yeah, we are still not come up to those levels. Hypertrophic cardiomyopathy, we'll come into those levels. I think we, is it 9 o'clock? Okay. So let us take a decision now. Can we break now and again assemble, say, tomorrow evening and continue, because it has been about 2 hours. And even though I may not feel tired, like the people who are listening may become tired. So I'm going to stop here. We are going to create a Zoom version tomorrow evening, same time, 7 o'clock. I will just go back 2 slides and start from that moment onwards. There are a few questions that has come, and these questions I will note it down, and we will again start from here. Unfortunately, sorry for exceeding the time. The intention of this particular session is not like the previous ones that you have heard, wherein everybody were time bound. The purpose today is to have clear-cut hemodynamic concepts So sometimes it might take longer time. I accept longer time duration. We will again sit tomorrow at 7 o'clock and we will rediscuss. From here, there are a lot more to discuss on various pathology. We have just come up to somewhere in the beginning of pulmonary artery. We have the entire left ventricle to go, aortic stenosis of various types to go, various left ventricular other outflow tract obstructions to go, more hemodynamic abnormalities like hypertrophic obstructive cardiomyopathy, restrictive cardiomyopathy, constrictive pericarditis, cardiac tamponade. So there are quite a lot of other pathologies to be discussed, and hence we will reassemble tomorrow. We will share with you the Zoom ID through Dr. Anil Singhi and through other sources to you. We are assembling again at 7 p.m. tomorrow. Thank you very much.
So may I end the meeting?
Yes, please.